Kia ora koutou, ko Charlie Maslin toko ingoa. I'm with the older persons team at Health New Zealand supporting the South Island, Te Waipounamu. Thank you for the opportunity to speak with you today. As mentioned earlier by Kelsey and Jason, our team is well underway in utilising the health data platform to inform the delivery of home community support services in Te Waipounamu. But I'd like to go back a bit and describe how 6th interRAI Casemix has informed the design of these services. As you all know, home community support services play a critical role in supporting older people to live and age well in their own communities. It is one of the most important and powerful levers we have to support aging in place and to manage pressure elsewhere in the health system. When home care works well, people stay well for longer, carers are better supported, and we reduce hospital admissions and early entry into residential care. For a long time, we've thought about and allocated home care as tasks to be completed in discrete units of time. We're now moving towards something different, a system grounded in need and measured in outcomes. Traditionally, we've broken care plans down into tasks, 45 minutes a week for meal preparation, 15 minutes for a shower. While this structure may simplify funding and workforce planning, it creates real problems as people don't experience their lives in 10-minute increments, yet the fee-for-service model asks them to. Care becomes fragmented and prescriptive. Providers are measured on their inputs rather than their ability to meet the needs of our clients and to improve outcomes. And perhaps most importantly, an hours-based system does not flex when a client's needs change. Health needs may deteriorate or improve, and access to informal care may change, but allocated hours of home care often remain static until a reassessment occurs. The outcomes outlined in the Healthy Aging Strategy, people living well, aging well, and having a respectful end of life in their communities, are often at odds with the way that we fund and monitor services. In response, we've developed a new service response expectation framework based on 6th interRAI Casemix. So instead of asking how many hours of care someone should receive, this Casemix-based framework shifts the focus from prescribing tasks to outlining expected service responses, basically from focusing on hours to outcomes. Through a bulk funded funding model, providers are no longer funded to deliver minutes, they're enabled to deliver care. That means focusing on restoring function where possible rather than maintaining dependency, adjusting services over time without constant reassessment, and responding earlier when risks increase. Importantly, the framework moves beyond function alone and incorporates client goals, recognising the role of whānau, carers, and natural supports. A key feature of the framework is the way it strengthens care planning through the use of 6th interRAI CAPs. Care plans for all Casemix groups are required to respond to each relevant CAP identified through the assessment process, ensuring that services are targeted to specific risks, needs, and opportunities for improvement for each individual. Rather than being a static list of tasks, care plans become a purposeful response to what matters most for the client, helping to ensure the best possible outcomes for each person. Clients are reviewed by providers who know the client, at least annually or sooner in response to change in need, and likewise 6th interRAI reassessments are completed annually or when required. This ensures that assessments remain current, responsive, and aligned to the client's evolving circumstances. This creates space for clinical judgment, cultural responsiveness, and innovation at the front line. It recognises that two people with the same diagnosis can need very different responses, and that effective support is about tailoring care, not standardising it. A further key shift is a change in how reassessments are completed. Under the new model, non-complex assessments for Casemix 2 and 3 will be undertaken by providers. This reduces duplication, decreases the number of cars up the drive, and improves the timeliness and responsiveness of care. At the same time, it frees up NAS capacity to focus on complex clients where specialist assessment, coordination, and system navigation are most needed. This framework was developed with stakeholders across the sector, including community providers, needs assessors, geriatricians, and consumers. Following extensive consultation, it has now been included in the National Tier 2 Home Community Support Services service specification, and this was first implemented in Te Waipounamu on the 1st of October 2025 and is set to be rolled out across the country over the next 2 years. The way this model is governed is just as important as the service expectation framework itself. In Te Waipounamu, Health New Zealand is working with several providers through an alliance model and that choice is deliberate. As can be seen towards the bottom of this framework, the emphasis is on shared accountability for system outcomes rather than focusing on compliance and contract management. Next slide, please. So this is an example of the dashboard that has been developed to monitor outcomes in the South Island. Some of this data is available from the health data platform that was shared by Jason and Kelsey earlier, including the interRAI quality indicators and the hours of service per case mix. The remaining measures are being sourced elsewhere for the time being. It will be updated monthly and both client level and system level indicators are considered. This information can be analysed across case mix groups, providers, and locations to further deep dives can be undertaken to understand trends over time and the impact of specific work streams. At an overarching level, the core outcome we are seeking to influence is the average number of days a year home and community support clients live in their own home, as can be seen in the top left. This provides a simple but powerful measure of whether home care is doing what it is intended to do, supporting people to remain safely at home for as long as possible. The dashboard includes a set of quality indicators derived from interRAI assessments that allow us to evaluate how services are performing and where improvements can be made. These indicators help us understand whether care is responsive, whether risks are being addressed early, and whether outcomes are improving over time. They are not used to rank or penalise providers, but to collaboratively inform quality improvement, service design, and commissioning decisions. In this way, data becomes a tool for learning rather than compliance. When funding, delivery, and data are aligned, the system can encourage innovation, improve flow, reduce avoidable hospitalisation, and support people to remain well at home for longer. Next slide, thanks. So when we talk about moving from hours to outcomes, what we're really talking about is trusting professionals to respond to need, designing services around people rather than tasks, and using data to improve care rather than simply account for it. If we do this well, the result isn't just an updated service specification. It's a system that supports individuals, empowers providers, and uses resources more wisely. Thank you. That's all I have.
Okay, thank you very much, Charlie. And I do apologise I didn't introduce you. I'm sure everybody noticed. You are, of course, you support commissioning for home and community support services using data and alliance approaches to enable equitable person-centred care with Te Whatuā in the South Island. So we have quite a few moments for questions. Would those, yes, online, I'll just bring there's two in the room. Go to the back first and then to Leah.
Charlie, thank you very much for that presentation. Just a wee query from Jen. Are you pulling your quality indicators from the CA or just the home care? And can you break down your dashboard to understand how many CAs and how many home care assessments are involved?
Yes, I believe we are. I do see that Steve is online here as well, though, so if I say anything wrong, please interrupt.
So why would that be useful?
That question for me, sorry?
Yeah, just initially, are you pulling your QIs from the CA or the HC?
I believe both.
The HC and
acronyms. We're not all familiar with these acronyms.
Sorry, no.
Just use words.
Just in terms of the Nai was asking why would it be important to know how many home care and how many CAs? Just because the quality indicators are quite different.
Contact assessment.
Sorry, I beg your pardon. Contact assessment as opposed to the home care assessment. So I think she's asking, firstly, was the other QIs were either the contact or the home care. We've answered that. That's the home care. So all of the QIs are from the home care. So the other part of the question doesn't really need to be answered. Sorry. Thank you.
Okay.
Robbie, did you have a follow-up comment?
I think the quality indicator section of that dashboard is based on the home care assessments, but some of the other measures are based on both types of assessments. And yeah, I'm sure it could be broken down how many assessments have been.
I do know from our focus group work, was Joe talked about that the contact assessments are really, really common and probably the bulk of the work. And so I'm intrigued that most of the QIs are only from the home care. But I don't know who wants to comment on that. It's probably a comment rather than a question. Robbie.
There's a different set of indicators for the contact assessments, and they are included as well. But I think just from that dashboard, it's just, yeah.
Okay, so there's a range of dashboards. It's a fantastic development. I really welcome it. Now,
Yes.
Leah.
Hi, Leah Pilapar from the University of Auckland. Thank you, Charlie, for your presentation. I just had a thought about the movement from hours delivered to outcomes. Is there any concern that might encourage providers to select more non-complex people with fewer? I mean, even though we're thinking outcomes, but they would be fewer hours to spend on non-complex people, or does the funding take care of that? Yeah.
The funding model is very complicated and takes that into account. And working in an alliance model means the providers are all sitting around the table and looking at the data together. And so if there was any discrepancy in how referrals were being allocated, that's something that would be brought to the table as well. But the funding model itself takes into account the hours delivered by Casemix and the number of clients per provider as well. Does that answer the question?
Yep, she's nodding.
The funding for each Casemix category is different. The level of funding for each group is different.
So you get more money for the more complex. So that might actually tip it the other way. You might be incentivized to assess everyone as really complex. And then, yeah.
Providers only do some of the assessments. They do the non-complex end. So they're only doing the CA assessments. The NASC, which you'd say is, independent, does all of the HC assessments at the moment. I don't think that there's any skewing it, though, from a provider perspective. Most of the contact assessments reasonably black and white. There's a lot more grey area, shall we say, in the HC assessment.
Okay. Good, Karen.
Just great to see the increased frequency of home care assessments, especially, and just wondering about the resourcing for that, because unless there was a significant change or someone needed some change, like a big change in their needs, there was we always work to a 3-yearly time frame. So looking at the 1 yearly plus checks in between just seems really great. But is that going to need a huge increase in staff? You said it's rolled out already in some districts. Has that been difficult to manage, going from 3 years to 1 year?
So this is a 10-year contract, so it will take time to implement, and we understand that the change isn't going to happen overnight. This is a shift in thinking, and so we do understand it will take time.
Yeah, great. And just one more question, is there any thought to other providers who are quite often who are the lead kind of managers of a person? I'm thinking of dementia services or hospice services who have clinicians who are able to complete assessments. Have they been included or thought about in this model at all? So that to stop all the duplication of cars up the driveway. So if you have someone from dementia services going in to complete a comprehensive assessment, they could do the inter-RAI assessment rather than their own one, and then the NAS go in, and all that. Same with hospice, really, too.
I don't believe that's been considered yet, but
Good feedback for you. Okay, another one from the room, from the Zoom room.
Hi, Charlie. Just from Karen saying thank you. Can you? She's asking, is it possible for researchers and home care support service providers to access the health data platform?
So there's currently a piece of work going on to get the South Island home care providers access to the data. Regarding researchers, that would be a Health NZ national question.
You want to say
Yep.
Robbie's gonna...
For researchers, they can apply for the inter-RAI data through the website.
So that's the inter-RAI data though, Robbie. What about this dashboard style Power BI data? Is it? I assume it's Power BI.
So I'll note that dashboard that I showed is different to the HDP. Not all of the measures on the dashboard that were presented today are available on that HDP. That's kind of cobbled together from what we in the South Island have agreed with our providers are measures that we feel are important and want to continue to monitor, the outcomes that we are looking for.
So I guess, do you feel that, Charlie, that this data would be useful for research, tracking, evaluation, all of those kind of things? And
I'm sure it would be. I'm not sure how researchers would get it though.
Yeah, that's I guess that's what the question was.
Yes.
How would a researcher be? Who's interested?
Um,
Maybe this is something we can take back to someone. I don't know.
Yes.
Who. Yeah.
Take it
Take
back
one.
to Jason would be the suggestion.
Okay. Jason, who was here earlier.
Yes.
Okay, good.
That national data platform, or the health data platform, whichever acronym we're going to use, it's a combination of inter-RAI data and provider data in terms of, service hours and things like that. So there's some really valuable data in there for researchers, I would think. But yeah, it would be going through Jason and that team to try and get access to it. Providers would love access to it ourselves, which is what Charlie's referring to at the moment. Noting, of course, this platform's pretty new. It's only been stood up in the last 7 or 8 months, and it went through a very quick pilot phase to being stood up. And there's still a lot of work in terms of getting the data into that platform, consistent data, shall we say, from all of the providers that deliver those services.
Yeah, and also to respect the provider's data, it does need to be as accurate as possible, and they don't want to be blindsided by things. So I guess that discussion about outside people accessing it would have to go back to the providers. I know, because I'm from primary care, that the PHOs, it's not an automatic thing to get access to their data at all. And I do remember when inter-RAI started, and the first interface that there was, the providers could get things and then they couldn't, and there's been a lot of ongoing development. So I guess will be lovely to see how you're going next year when you've had a year's experience in the South. Robbie, do you want to make any? He's shaking his head. Okay, so we are just at time. Charlie, do you want to make any last comments?
No, thank you for your time today.